meetings with Zoom.
Yeah, meeting is now streaming live on YouTube.
It's not come yet. I have YouTube.
Yeah,
You know.
not on YouTube yet.
So I'll push questions to Sampath sir.
Yes, sir.
So
Yes, of course.
It's not come yet. I have YouTube.
Yeah, not on YouTube yet.
So
It
I'll
is
push
live.
questions to Sampath sir.
Yes, sure.
Yes,
Sure.
We are live.
So it
sir.
is live now.
we're live.
Yes.
Yeah.
Okay. So, very good evening to everybody who's assembled. I think those of you who have joined in and those of you who will be joining in now, I think this is for the very first time that we have explored conducting something like this, IFAS Journal Club. Because I don't know if any other society does conduct journal clubs like this, but I think this is probably for the first time that we are conducting one in the Indian Foot and Ankle Society. A very interesting thought came to me. In fact, it's a WhatsApp forward which came to me today, and it says, let me just read it. It's from William Osler. It says, a doctor is a student till his death, and when he fails to be a student, he dies. So this is, I think this was very apt, and it came in exactly today. And I said, maybe I should be starting with this. And with this whole purpose, I think the journal club is something where all of us are going to learn, and it should be an extremely learning good activity for all of us. So the topics, and of course, I would be very thankful to Dr. Rajiv Vora, the president of the IFAS, who has told me to entirely conduct this journal club and to go ahead with the topic selections and all. So what I was noticing, I just was thinking for the journal club itself. So how do we measure the success of any procedure? So supposing we have conducted a procedure and we want to see how successful it has to be measured by some kind of an outcome measure. And until unless we have an outcome measure, we won't know if the procedure is successful, we have helped the patient or not helped the patient. So the different things we can look at it subjectively or objectively. An objective assessment is always got with a lot of constraints. There's a time constraint to all of us. We can't do all it. There's a bias which comes in. So if we feel, if I have operated on somebody, I feel that I have done a good job. So my bias would come into that. So even though we can add up, or maybe you can eliminate these to some extent, there will always be some inter-observer and intra-observer variations which can creep in. If we look at the subjective questionnaire, or if we look at subjective object measures of outcome, so there are always different things which come up, especially in a setting like India. We have to consider the IQ of the patients. We have to look at the literacy levels. We need to see if they can consent to filling up forms and all that, and how truthful they are in answering the questions. So all of these would definitely be adding up to the challenges of conducting a subjective outcome measure. So with this background, I thought we should go ahead, and that's the reason I thought all of us at the IFAS should be following some kind of an outcome measure whenever we are presenting our cases, whenever we are speaking in conferences, or whenever we are publishing. And with that intent, I thought we should be having a first journal club on outcome measures in foot and ankle surgery. So let's begin with, let me just introduce all the speakers and also the mentors today. Of course, Dr. Rajiv Vora, the president of the Indian Foot and Ankle Society, is here. So he will be there. He will be presiding and he will be conducting the sessions. Then Dr. Mandit Dhilan, who hasn't joined us in yet, but he should be during some period of time. He's been mentoring us for this entire journal clubs. So of course he needs no introduction. Dr. Mandit Dhilan is known to, I think, not just people in India, people abroad too. So he just doesn't need any introduction. Then to lead us today and to moderate all the goings on, we have Dr. Sampath Patil, who is the former president of the Indian Foot and Ankle Society, an avid reader, an avid publisher, and who has come up with lots of new techniques which have been published in various journals, not just in India and abroad. He would be taking us through the journal club. And one of the topics very close to his heart is to have a special scoring system for the Indian patients, and which I'm sure we should be able to accomplish in a very short while from now. Then as speakers, we have three people who are remaining today. Actually, six were identified. Then today, the others couldn't join in, and we have three of them on board. So we have Dr. Siddharth Sharma. Dr. Siddharth Sharma is an associate professor of orthopedics at the PGI Chandigarh. So he has been in the forefront of publications and orthopedics from a very long time. And he has a lot of papers to his credit. And of course, we can definitely look forward to an excellent session from Siddharth. Then he was the first one who volunteered. The moment I put this up in the general clubs in IFAS, he said he would be the first person who volunteered to do the general club, and I'm extremely happy. So he would be the the third speaker on the thing today. Then we have Dr. Vikram, who will be the first speaker today. Dr. Vikram did his post-graduation from the CGS Medical College, hailing from Nagpur, and he is currently working as a foot and ankle fellow at Cardiff. So he's working with Mr. Rhys Thomas, and he's been there for a year almost, I think, and he should soon be completing. And this is the hospital, is University Hospital at Landow. And welcome, Dr. Vikram also. He would be the first presenter. And then we have with us Dr. Anuj Chawla. Dr. Anuj Chawla, after completing his post-graduation from India, he was in Singapore at the TTSH, the Tan Tock Seng Hospital, for a period of 7 years, where he picked up his skills in foot and ankle surgery. Following that, he has completed a foot and ankle fellowship, and this has been at the Robert Jones and the Agnes Hunt Hospital at UK. And currently he's working at the CK Birla Hospital as a consultant in Gurugram or Gurgaon. So welcoming all of you, and let us go ahead. So I would just hand this over to Dr. Sampath now. Dr. Sampath.
Good evening. Thank you so much, Ajay sir. It's a great initiative. Thank you for starting this journal club. And first topic for the journal club is really interesting, as you have elaborated well, that we have to know some scoring system. And let us start with looking at what literature says about these scoring systems. So may I invite the first speaker who is going to get us through an important article about what is the most commonly used scoring systems.
Yeah. So
once you go through it, we will discuss this article as well. Please go ahead, Vikram sir.
Yeah, okay. Hello, everyone.
Vikram, hi. Sir, can we give it another 5 minutes before we start? There was some problem with the live link. So
Sure.
People are getting on, and there's no point doing it alone.
Sure. We'll wait.
5 more minutes. The link has changed somehow on YouTube. So I'm putting that link over to everyone.
Yeah. Till that time, we'll keep on discussing few things.
Yes, sir.
Ajay sir, it's really an important task to conduct this journal club. People
Yes.
who have done it abroad, I'm sure everyone will have a different way of using journal club. Few people, they read article who are used to present or publish, they read it in different perspective. People who use it in research universities, they read it in different perspective. People in India, we are not used for this journal article, but people who are using it, we use it for our own purpose, like how we can utilize this particular technique in our practice. So everyone has its own way of conducting this journal club. I think since India, we have not done it on regular basis, and particularly IFAS has taken really a great initiative. What we'll do is we'll try to read this article. We'll try to see how to read these articles and how it reflects in our practice, or how we should use it in our practice. What are your views, sir? Ajay sir?
Yeah, I think so. That is fine. I think that's the whole idea, and then we can. I think I think all the presenters are actually going through the articles, and the articles incidentally have been shared with all the members of the IFAS
Great.
3 days ago, so that everybody could read up, and the discussions could become quite lively and interactive.
Absolutely. And
That I think Dr. Sampath is taking an initiative to develop something like Indian score. And there are certain things which others people are not doing, like squatting, like this is one which
Yes,
none of
exactly.
the scores would think of even putting it in. For us, it is so important. Then sitting cross-legged and certain postures, which are so important to the Indian patients. I think it will be a great thing if we can put these things along with the other scores and validate, because now it is the time where we are looking for the patient-related outcomes. So it is
Exactly.
more and more we are going into that. So I think that will be great. Uh, so
So
it's, we have a message that YouTube is working well. Is it, Indrajit?
Yes, sir, it's working. The new link is working somehow. I don't know. The YouTube changed the link. We've
So should we proceed or should we wait?
So I think there are only 10 people now. So we can
Okay.
give it another 5 minutes and then start.
Okay. So what was the strength earlier? Any idea?
So there were 14 people waiting on the previous link.
Okay.
Yeah.
So that will be a great thing if we can come up with something like a score which is relating to the Indian requirements.
yeah, IFS score, something like IFS score.
And we can call it as an IFAS scores.
Yeah, because Rajiv sir, as you correctly mentioned, some of our patients are so happy and they will come back saying that, sir, I can work in my fields, or
Yeah.
I can sit cross-legged, or I can squat, For them, that is the most important thing. I mean, of course, we have mixed culture. Some of the urban people may not see it.
Yeah.
But
We can walk this number of blocks. No one understand the blocks here.
actually,
Yeah, exactly.
So this becomes very difficult for a person to say how many blocks, how many things. So their requirements are entirely different from us.
like when I was publishing for the one of the Achilles series, one important point which patients gave me feedback is with weak Achilles, they could not walk in the field where there is mud. They could not
Yeah.
get their feet out of that mud. So that kind of strength is really has to be measured. That someone who walks in the fields, you know, those criteria are also important from farmers' perspective.
And I think one of us develops or you develop it, and then you send that score to and let us validate into, in different conditions.
Actually, we are into it for the last few years. Only thing is validation is lacking. Myself and Ajay sir had discussion. I will share with you people with
Yeah, we can use it for our patients also in trauma or wherever you want.
Yeah.
We can follow these scores after 6 months or something, so we can get some.
Absolutely.
That will be great. More than happy to contribute into this.
Yes, I think so. Once we have it multi-center, means all across
Yeah,
India,
yeah,
because
yeah.
even within regions we have a lot of changes within the regions. But I think one thing which is most common to all of India is squatting and sitting cross-legged,
Absolutely.
irrespective. I think that would probably would.
And then we can match up at one score. Let's say if we want it to be AOFAS and or anything, so we should have two scores. One is ours and one is the other standard score, and see
Correct.
how they frame on excellent and moderate, severe, or excellent. I think that will be a good thing to do.
And Rajiv sir, very
Exactly. So
yeah, sorry. Very interesting point
yes,
is even this article which we are reading, um, few of the most commonly used scores are still not validated, but they are used because they are easy to use.
Yeah.
So then because I was waiting for so long, last 2-3 years to get it, for getting it to validate, but then I understood that one of the most commonly used scores are also used, but actually
they're
may
not.
not be validated. But it's important from patient's point of view, because if you gave AFS score to a farmer, as you correctly said, walking few blocks is not going to translate into his this thing.
So that is what I actually think, that we need to work on this on IFAS, and we can say that this is you can call it as a rural score of
I mean, IFS score should work because this translates well to all our mixed population.
Yeah,
Sitting cross-legged.
So that will be a great initiative, and if we take. So, Indrajit,
Indrajit, have you shared the new link?
Yes, sir. I think we can start. We have.
Yeah, I think we should
request.
move ahead with it.
Okay,
Okay.
I'll just share it to.
Should I start then?
Yeah.
Dr. Induji, shall we start?
Yes, sir. Please.
Please, Dr. Vikram,
Okay.
please.
Okay, yes. Hello everyone. I am Vikram Kandhari. Thanks for the kind introduction. I'm really happy to be the part of the first IFAS web series on the Journal Club. And I will now begin my presentation. Thank you. So I'll first start by providing everyone with the overview of my presentation. I'll begin by introducing the topic and then move on to the basic details of the article. Then we will discuss the methodology and results of the systematic review, and I will end by discussing briefly about my interpretation of the review and the future of patient-reported outcome measures for foot and ankle practice. So I hope we all agree that patient outcome evaluation is the litmus test of our clinical practice. Most outcome evaluations are moving from an objective to a subjective mode of evaluation and are more patient-centric now. But since there are so many patient-reported outcome measures available, clinicians often find it difficult to choose one for their clinical practice, as they have superficial understanding of their content and applicability. So I have chosen a topic which will provide us an up-to-date summary of the outcome evaluation tools of foot and ankle. So I'll first briefly tell you what is an ideal outcome evaluation tool. An ideal outcome evaluation tool is reliable, reproducible, responsiveness to small clinical changes, and accurately reflects the patient's perception of outcomes. Most of the available outcome evaluations concentrate on mental health, pain, and function pertaining to the sports-related activities and activities of daily living. Outcome evaluations of foot and ankle can be generic, they can be disease-specific, or they can be region-specific. With this basic understanding, now we will move on to the article. So the study we are discussing is a systematic review of the outcome evaluation tools for the foot and ankle. The lead author is Dr. Vinod Panchbhavi. He is the senior author of the study. He is a known face to the Indian Foot and Ankle Society. He is a subspecialized foot and ankle surgeon practicing in University of Texas. None of the authors have any potential conflicts of interest for the study. The study is published in Foot and Ankle Specialist, which is a peer-reviewed bi-monthly journal with international distribution and is targeted to the caregivers in foot and ankle, mainly the podiatrists and the orthopedic surgeons. Though this review is categorized as level 3 evidence, I believe it is questionable, which we will explore as we go along. The main purpose of the article is to find the most frequently used outcome measurement tools in foot and ankle and discuss few issues pertaining to them. Since the research question is mainly epidemiological, there is no formal hypothesis. The intention is to explore all patient groups, foot and ankle interventions, and all possible outcome measures in the review. With regards to the methodology of the systematic review, the methodology of the systematic review is a bit weak. I think there is no mention of protocol being published or any link provided for it. The systematic reviews usually have a registration on an online data, but this review is not registered anywhere. The eligibility, they included all the published studies using the foot and ankle outcome evaluation tools before and or after surgery. They included all the articles published between January 2013 and 15th November 2017. What the articles which were excluded were the systematic review, comments to the editor, and the case report. Because they've included all the case series, that is why I said the level of evidence is a bit questionable, because the level of evidence of a systematic review is dependent on the articles which they included. So if they've included the articles till level 4 evidence, then basically the level of evidence of this article should be level 4. They have included only one published resource. That is, they searched only the PubMed and not the other resources like the Cochrane database or the Embase or Ovid database. Thus, I feel it is unlikely that they would have included all the studies. They have a very clear search strategy and a very comprehensive one. Their study selection is a bit vague. In systematic reviews, usually they give a search strategy and they do the search in one stage. But this article does the search in two stages, in which in the first stage it applies the search strategy, and in the second stage they apply the limits to the search strategy. I think this could have been combined into one and presented just to avoid confusion. In the first search, they found 2,122 studies, and when they applied the limit, this was reduced to 723 studies. They did not formally do a skim and scan of the title and the abstracts, but ended up reviewing all the 723 studies. They excluded 34 studies based on their exclusion criteria, and finally 669 studies were included for a full text review. Their primary search started with putting a search strategy for 34 outcome tools, and when they did the review of the included 669 articles, they additionally found 42 outcomes. So in total, they've looked at 76 foot and ankle outcome tools. They have not provided any formal Prisma flowchart of their search strategy. They have specified the data items they looked at in their review, but they did not provide any details of the data collection process or a risk of bias assessment of the studies or any summary measures or how they synthesize their results. To determine the most frequently used foot and ankle outcome measures, they include the data they looked at was the number of times the scoring system appeared in the published articles. They also looked at the total number of patients the scoring system evaluated. And in the results and discussion, they concentrated on 10 of the most frequently used scoring systems. So this is a list of all the 10 most frequently used scoring systems which they found in the systematic review. The American Orthopedic Foot and Ankle Score tops the list with respect to the number of publications it appeared in, and also with respect to the number of patients it evaluated. When we look at combination of scores, the most common combination was use of visual analog scale and the American Orthopedic Foot and Ankle Score amongst all the included studies. So from the top 10 outcome evaluation scores are generic. And 5, query 4, why I write that? Because one of the scores, foot and ankle ability measure, they have categorized as a disease specific, but in other resources, it is basically a region specific score. All the scores, all the top 10 scores are self-reported, but AOFAS is not a self-reported score. It requires physician and patient input both to complete it. So it is not a true patient-reported outcome measure. 6 of the top 10 foot and ankle scores are reliable and disease-specific scoring systems. Functional FFI is validated for use in rheumatoid arthritis and osteoarthritic patients. Ankle osteoarthritis index is used for to assess the patients with ankle arthritis. FAOS, FADI, and FAM are used. They are validated for use in chronic ankle instability, and FADI is specially validated for patients of athletic population patients. SMFA is a generalized score which is used for musculoskeletal diseases and patients with musculoskeletal injuries. The generic tools VAS, SF36, and SF12 are also amongst the commonly used scores, but it is argued that they are less sensitive and less sensitive than the disease and the region-specific tools. But their use is justified if we don't have any specific disease tool to assess the pathology. We talk about the most frequently used score, which is the American Orthopedic Foot and Ankle score. It is basic. It basically covers 4 regions, and these regions, the score for these regions can be used individually. They cover the hindfoot, midfoot, the great toe, and the lesser toes, metatarsophalangeal and the interphalangeal joint. This continues to remain the most frequently used outcome score for foot and ankle pathology since its publication. It was first published in 1994, and all the progressive systematic reviews which have happened on this topic since then have categorized this as the most frequently used outcome measure, probably because of ease of application. But surprisingly, though it is the most commonly used one since at least 2.5 decades, it is not valid, not reliable, and it is considered not responsive to minor clinical changes. There is also potential for statistical errors with its use because it takes into consideration both the ordinal and the interval data. And there are no clear guidelines for data interpretation. Thus, it can't be used for comparison in between studies. 40% of the emphasis in the score is on measurement of pain. Thus, it is considered far from ideal. All these have been highlighted in the position statement, which was laid out by American Orthopedic Foot and Ankle Association on American Orthopedic Foot and Ankle score. And they agree that continued use of AOFAS score is not recommended. Though this came out in 2011, till date, it continues to be the most frequently used score. All these findings, as I said, have been reflected by the systematic reviews done in 2004, 2013, and now in 2019. So my impression from the systematic review, the title highlights well the study design, and I think it is a good study design to discuss the topic of the review. The abstract is well structured and concise, gives good ideas about the essence of the topic, but there are some typographical errors. There is a match between the dates of the studies published, which are included in the review, in the main text and in the abstract. The introduction is well written. It has a purpose line, and it highlights a good topic of discussion. Methodology, as I mentioned, is weak, and it is not written according to the PRISMA guidelines. Thus, it has potential for high risk of bias. According to the level of evidence, I think this is a level 4 evidence study, not a level 3, the way it is published as level 3. The results are in line with the purpose of the study and are well depicted. There are some typographical errors in the tables, and as I mentioned, FAM score is wrongly mentioned as the specific score, where it is actually a region specific score. The discussion is well written. It mentions about the PROMIS score, which is hopefully the future of the patient outcome measure. And the drawback is it does not mention about the limitations or doesn't highlight the future research direction. Conclusions are almost similar to the earlier published reviews on the same topic. The topic of the systematic review, I think, is very relevant to the clinical practice world over. And I think from the systematic review, it is high time that we change our practice to use more valid scores, the options being FAM and also PROMIS, which we'll look in the next slide. Some of the foot and ankle scores which can be used, which are validated and can be used, include the AOS foot and ankle questionnaire. This is a region-specific questionnaire, and it evaluates the pain, function, stiffness, and swelling, way and shoe comfort of the patient. It is considered reliable. It has high mathematical quality, but its drawbacks are all the data has to be entered into a computerized spreadsheet to get the final result, which is a bit impractical. It also doesn't evaluate the quality of life of the patient. And as other scores, it lacks information on minimal detectable in the scores to evaluate the benefit of the clinical benefit of the treatment. FAM score is another good one, which mentions which is a region-specific score. Its content is validated, its construct is validated, it is reliable, and it is considered well responsive to the small clinical changes. It evaluates the activities of daily living and the sports-related activities. It is versatile, so it can be used in many pathologies, and its application is considered quick and easy. Promise Score is a patient-reported outcome measurement information system. It is a free online tool. It mainly is a subjective score which evaluates the physical, mental, and social health of the patient. It is based on computer adaptive technology and item response theory. What this means is whatever response the patient puts in the score, the further questions would be based on the responses which the patient has already given. And it is a question bank of 121 questions, but the actual score, when it is evaluated, maximum 7 items are included in it, and it takes less than 1 minute to complete. Its advantages are the preoperative value of score can be used to likely evaluate the benefit of surgical intervention. It is more patient-centric, and for the treatment-related decision, it includes the patient in treatment-related decision, and it thus helps to better manage the patient expectations, and it has the potential to compare outcomes in between studies. Any questions?
Thank you. I mean, if we have some questions for you, we'll ask regarding it. And you have evaluated this paper very nicely for us. And you have summarized all the points, including the level of evidence. And it's really, I mean, the topic is really relevant, that few common topics which are common scores which are widely used, but interestingly, they are not validated, because all of us we use AFS score. Till now, I don't see any questions coming to us from online, but I would like to ask some questions to you once we have one more presentation on AFS score by Dr. Siddharth, so that then we'll have collective questions to yourself and Dr. Siddharth, and then we'll go to the next article, so that till that time we'll get the questions and collectively we can answer those questions.
Thank you, Mr. Sampath. I'll stop sharing my screen so the other presenter can go on.
Yeah, please. Dr. Siddharth.
Yes, sir.
Yeah, so I have requested Dr. Siddharth, since we read this article and Dr. Vikram has very nicely evaluated this article, that few of the common scoring systems are AFS, VAS, and the SF36. So I have requested Dr. Siddharth to give some presentation on AFS, how this is the most commonly used score, and Dr. Vikram has mentioned that it's still not validated. So let us hear from Dr. Siddharth about AFS score, and then we'll discuss about this article. Over to you, Dr. Siddharth.
Right, sir. So just give a moment. I'm just going to the first slide now. Okay, Sampath sir, can you see the screen?
Yeah, we are able to see your screen now, sir.
Okay, so thank you, sir. Thank you, IFAS, for this wonderful opportunity. And as Dr. Vikram has told us.
Yeah, sorry, we can see your screen, but yeah, that's it. Now your presentation is
Right.
on. Go ahead, please.
Okay, okay, sir. So Dr. Vikram mentioned in his systematic review, and he evaluated that review very well. And we know that the IFAS clinical rating systems are the most widely used. This is, in fact, the most commonly used score worldwide. Now, this was developed in 1994, and it was loosely based on the Harris-Hip score. But you will be surprised to know in 2011, the American Orthopedic Foot and Ankle Society themselves came out with a statement saying, please do not use this score. And then in 2017 and 18, again, there were publications on this topic discouraging strongly the use of the AFAS score. Now, why did this happen? Why did such a good score, so-called, fall out of favor? So I've just tried to emphasize three problems. Now, there are many problems, But let's just see 3 problems. And when we see these 3 problems, we'll also understand what are the problems with the commonly used foot and ankle scoring systems. So the first problem is that there is too much emphasis on pain. 40% of all the IFAS score depends on the pain. So if your patient does not have a painful pathology, if stiffness was, let's say, a major problem, then you would be grossly underestimating the problem because the patient simply doesn't have pain, right? Second thing is the issues with clinical significance. So like Dr. Rajiv Vora sir was saying, we need to categorize our patients into excellent, good, fair, and poor outcomes. However, the categorization of this score is arbitrary. So there are no validated studies saying that the excellent patient is better than the good one, the good. So this is very loosely based. And the other concept is the minimal clinically important difference. How much should my patient improve on the next visit? Should he improve by 5 points, 10 points, 20 points? So again, this is not very clear when it comes to the IFAS score. Now the third, and I would say the biggest problem, is the issue of validity and reliability. And I'm just going to introduce these concepts for some of our younger readers because I hope there are some postgraduate students walking. So I took the liberty of putting up Dr. Anuj's photo here because I believe he's the smartest of all of us here. So let's say, for example, Dr. Anuj weighs 75 kilos. And I have this machine. It says that he weighs 75 kilos. So this is an accurate measurement. This is a valid measurement. This is what we mean when we say valid. So it is the precision, it is the accuracy of that instrument. Now let us say he weighs 75 kilos, but the machine says 90 kilos. My God, this is wrong. This is not valid. This is not accurate, right? Now, you also talk of reliability, which is also repeatability. So let us say he weighs 75 kilos. Today he steps on the machine, it tells 75 kilos. Tomorrow and the day after he also weighs and it turns out to be the same. So the machine has good repeatability, good reliability. So this is what we mean by reliability, right? So some machines or some scoring systems, they can be valid, but not reliable. So it may tell you the correct thing the first time, but when you go ahead and repeat it, it may not be, the repeatability of that thing may not be good. So this is a valid but not reliable measurement. Another thing is that the machine may be reliable but not valid. So every time when Anuj gets on the scale, it tells it is 90 kilos. Now the machine gives the same value every time, but this is not the correct value. So if you had to choose one of the two things, you should choose a valid thing, but not necessarily a reliable thing. So what is a minimal clinically important difference? Now, let's say in the lockdown, Anuj eats lots of pizzas and burgers. His wife is giving him lots of stuff and his weight increases from 75 kilos to 90 kilos. And our machine is able to detect that change. 15 kilos, the machine is able to pick up. So this is a change that the score or the machine can detect. However, let us say he exercised well and he only put on 5 kilos of weight, but the machine is not able to detect this change. So this is the minimum clinically important difference. So, and the minimum clinically important difference is the difference that as clinicians we want to detect. So let us say we want to see a minimum change in the IFAS score of 10, but whether that change in 10 actually reflects an improvement. So this is one of the issues with the IFAS score. So how do we determine whether a score is accurate, whether it is valid? So we compare it to another well-established score like the SF36 score or the EQ5D. Now these are gold standard scores. And when they compared the IFAS score to these scores, they found that the validity was not very good. How do you compare determine the repeatability? So you ask the patients to take the score on multiple occasions. And again, when they did the IFAS measurements, it was found that this repeatability was not good. Now, one of the main reasons why the repeatability was not good is because it has the element of examination. And today you may measure the ankle plantar flexion as 60 degrees. On the other day, you may measure it as 50 degrees. So there is an element of subjectivity when it comes to clinical examination. So the bottom line of this short and sweet presentation is that the IFAS score is no longer recommended even by the American Orthopedic Foot and Ankle Society, the guys who came out with the score in the first place. We should be using validated scores, and some of the journal club articles will tell you. And like Vikram has said, the foot and ankle ability measure, the foot and ankle outcome score, even the AOS score, the MOX-FU score, which Anuj is going to show, these are all good scores. They have been widely validated. They should be used. And the other bit is, when you are using a foot and ankle score, please also look at an overall quality of life score, right? Because your patient may be happy overall. The patient may have a very good foot and ankle outcome, but the patient may be sad. So when you ask him, he may say, "हाँ डॉक्टर साहब, मेरे पैर तो ठीक है, but I want to kill myself. I am not happy overall." So please do not concentrate on the foot and ankle alone. Please also look at the patient as a whole, and we should always use a combination of scores. So thank you.
Thank you, Dr. Siddharth. Very well explained and very nicely explained, because even I was in doubt what is meant by validation, what is the minimum amount of clinical this thing. So very well explained, and not to juniors, but even people like us, it is
it's a wonderful presentation. It's a wonderful presentation.
So we have a couple of questions for Dr. Vikram. Dr. Vikram, very nice evaluation of the clinical this thing. What we want to ask you is, since IFAS score was not, it was commonly used but not validated. So I believe now second SF36 was the commonly used scoring system, correct?
Yeah.
And that is validated.
Yes.
Yeah. So we can say that the most commonly used validated system is SF36.
The second was actually a visual analog scale, not SF36 was the third one.
Right. So both are vast.
Validated. They are validated, but in like generalized. As I said, these scores are generic. They are they have generalized applicability, and they are validated. When people say they are validated in various other aspects, but not specifically to foot and ankle. So they would look into the generalized aspect of the complaint, but not specific. As you said, walking on mud, walking on pebbled ground, unlevel ground. That is where we actually come to know where exactly the pathology is, and have we changed that with our interventions like ours, or are the patients really finding it difficult even after that? So I think it is a good score for a generalized validity, but we should combine it with a specific foot and ankle score, at least a region specific score, if not a disease specific.
Great. So he has made an important point that it is a generic, it is region specific. So region specific means specific to say hind foot, mid foot, or forefoot. So just give us a brief that which was the most validated and region specific score. As you mentioned, probably it was AAFM.
Yeah, foot and ankle ability measure. The review mentioned it as a disease specific score because it was actually introduced for the chronic ankle ability patients. But other studies have validated it with other regions as well, and it is considered a versatile score. So that is an option, and it was fixed on the list in the top 10 scores which are used. The problem with changing of practices, most of the studies which are published use a certain score, and if you suddenly change your practice, inter-study comparison becomes difficult. But if we slowly start using FAM score, which is already being used, it is amongst the top 10, then down the line, we will have studies in which we can compare and contrast with the history as well. The promise, as I mentioned, is again a very good online tool, which is a free tool, which has been developed after a lot of investment, and it uses predictive technology, which will be good. But again, it does not have any history with us. It is not used that frequently. It is not in the top 10 list. So I think even if we start using that, we should also keep FAM score in picture.
Great. And one last question from my side. Why do you think that this was accepted as level 3, and why do you say it is level 4 evidence? I mean, this particular paper. Why do you think, what would have made them think that it was 3? Because obviously it is accepted in peer review journal. What would have been the factor?
The reason for it.
Yeah, a reason for.
Yeah. I'm not very sure what would be the reason for it, because the reviewers, I think, should have raised that point. Though it is accepted in a peer-reviewed journal, it is not one of the higher rated ones. It does not have a very high impact factor. Its impact factor is 0.93. The second reason I can see, it also targets podiatrists. So it has quite a bit of readership of podiatrists as well, which may or may not. I'm not against anyone, or I'm not pointing fingers to anyone, but they may not have so much of research background. So sometimes these articles get pushed through without having a very good statistical review or things like that. So that must be the reason. But I cannot pinpoint a reason from my end or from the review. But to be really just, it should be categorized as a level 4 evidence.
Yeah, that's a great point, because we are only interested in technical point. I mean, that's fine. We don't want to point out to anyone. Just as a technical thing, I wanted to ask you, because even we submit articles and we should know what is the level of evidence we are looking for. Great.
Yeah. So if we end up including case series in a system review, then the level of evidence is level 4. If you are only limiting to comparative studies or case control studies and neglecting the case series, then it will be level 3 and above. But if you are including case series, it automatically goes to level 4.
Great, great. Dr. Siddharth, do you have to add anything to this particular article, or shall we go to the next article?
So, sir, just reinforcing on what Vikram has said, in the older days, they used to have this terminology, garbage in, garbage out. So a systematic review or meta-analysis is only as good as the articles that go in it. If you put in level 4 articles, the meta-analysis is also going to be level 4. But if you have level 1, then level 1. So I agree with him completely.
Great. Dr. Ajay sir, Dr. Rajiv sir, any questions for the first article?
I'm learning.
Nothing. I think we should.
I'm learning. That is all I have to say.
So shall we go to the next article?
Yeah. Yes, I think so.
Please.
Great learning.
Dr. Anu. Yeah.
Anuj.
Yeah. So good evening, everyone. Thank you, Dr. Ajoy, Dr. Rajiv Vora, and Dr. Sampath for letting me be a part of the IFAS Journal Club. So I'm Dr. Anuj. I'm working as a consultant orthopedics and foot and ankle surgeon in CK Birla Hospital, Gurgaon. So yes, I think I also have learned a lot of things from the previous two speakers, and I wish to have a weighing machine which actually weighs 75 kgs, and I would say that that would be both reliable and valid as well. So let me go through my article for today. So this is an article, I mean, for a score which I think I have used most often during my fellowship period in UK, as well as when I was working in Singapore, which is Manchester Oxford Foot Questionnaire. So I just wanted everyone to have an insight or an introduction of this score particularly. I found this article in the journal Foot and Ankle Surgery, which was published in the year 2019. So this is comparison of MOX-FQ and the self-reported foot and ankle outcome score in patients undergoing foot and ankle surgery. This article primarily is based from Germany. If you look at this journal, this is an official journal of European Foot and Ankle Society. The CITE score for this journal, which is the number of citations per article, is 2.3, and the impact factor by itself is 1.363. They did not mention what kind of level of evidence it is, but I think I just came up with my inference, and during the discussion, I would just highlight on that. So I think probably this is going to be a bit of a repetition of what has already been discussed, but I would still like to go with it because I think by the end of the talk, we should know what does a patient-reported outcome measure means, and all the and I'll also be discussing about all the reliability, responsiveness, and other parameters that actually Siddharth explained, but obviously without my picture in that. So patient-reported outcome measured by itself, they are the most reliable because they are reported by the patient, unlike the most commonly used AOFAS score, which is not primarily patient-based, but it also includes physician's assessment as well. So they have been proven to be efficacious for orthopedic procedures as well as in various trials, and they are good in defining the overall outcome of the healthcare as well. So talking about the scores that are being described in these, so I would just be, I think it looks a bit heavy slide, but I'll just be discussing about what are the questions that are available. So we have the MOX-FQ score or Manchester Oxford Foot Questionnaire. This itself is a 16-item instrument which is answered on a 5-point Likert scale, which means it has 5 answers. So the 5 answers are same, which is none, rare, some of the time, most of the time, and all of the time. And their scoring is from 0 to 4. This score itself was developed as an outcome measure for hallux valgus surgery way back in 2006. And after that, it has been slightly amended so as to incorporate or include all the kinds of foot and ankle surgery. When it was originally published, I think 2007, there was a comparison of this score specifically for hallux valgus, and it was seen that its performance is actually comparable to AOFAS, and it is better than the SF36 scores. So it per se is divided into 3 subscales. The first one is the walking and standing problems, which has 7 items or 7 questions in it. Foot pain is the second one, which has 5 questions of all 5 items, and the third one is social interaction dimension, which has 4 items as well. So overall, when you incorporate the whole score, MOX FQ index comes out as a summary index, which just gives you an overall outcome after any form of surgery. So if you look at it, there are total 16 questions. So 0 to 4, that means the total score still becomes 64. So the raw scores are then converted to a metric scale of 0 to 100. And please note that the high scores means that it is a worst stage. So it has excellent psychometric properties in terms of reliability, validity, and responsiveness. So, and as I mentioned, I would be discussing about it as well. So when I was doing my fellowship, I think every patient who comes to the clinic, this form or MOX FQS score was given to them, and within maybe hardly 2 or 3 minutes, they would fill up this form and give it back to us. So I think another aspect of doing any form of scoring is that it should be acceptable to the patient. That means it is easy for the patient to understand and to use as well. And of course, it should be reliable and consistent as well. So the next one is the self-reported foot and ankle score, or IFAS. It is originally based on New Zealand total ankle score, which was used for measuring outcomes after the total ankle arthroplasty. And then it was later on adapted by the Swedish specifically for ankle arthritis in 2012. So it is even easier with only 12 questions, incorporates with 5 response items. And all these 12 items are actually ungrouped, which means they are not really divided into different subsections or subscales. But I think for the purpose of comparison, in this article, the authors divided it into 3, in which pain had 7 items, limitation of function had 3 items, and others was just 2 items, which are probably miscellaneous or not really linked to or cannot be categorized into one particular heading. So it has originally been proven to be valid for forefoot, hindfoot, and ankle score. And the score was scored to 48, and this is not something which was converted to 100. The difference between SEFAS and MOXFQ is that in this case, the low score means worst stage actually. The third one is a foot and ankle outcome score, which I think there was a brief discussion about it previously as well. So it's a 42-item instrument. It was one of the most validated or most frequently used foot and ankle score in all the scores that I am talking about. And it was published way back in 2001. And it was an adaptation for knee injury and osteoarthritis outcome score. So it has 5 domains, which is pain, other symptoms, activities of daily living, sports and recreation, and foot and ankle related quality of life. Again, with the 5-point Likert scale and 5 answers to it. But if you look at it, it's a 42-item instrument, so there are a lot of questions being asked in this. I don't think we have to go into it, but yes, this is just a brief outcome of how the score looks like. So fourth one is the SF36 that they talk about, and we have already discussed about it. It's a generic patient-reported outcome measure, which actually deals mainly with the health-related quality of life and not specifically with foot and ankle conditions. It had 8 domains in which it is divided, or 8 subscales. And a total of 36 questions, and this is from where SF36 name came up. So, which is the domains are physical functioning, physical role, emotional role, social functioning, mental health, energy or vitality, pain, and general health perception. Again, I'm not going into the details, it is widely available online. And the last but not the least is the numeric rating scale. It also tells about pain and disability from foot and ankle. And it's a simple numeric scale in which 1 means best and 10 means the worst. And we ask the patient from 1 to 10 with regards to foot and ankle, how bad do you feel? So it is kind of similar to VAS as well. So the aim of this article as such, I mean, this was just a background about the scores that are being used. But the aim was compare psychometric properties of MOX-FQ and CFA score in patients undergoing foot and ankle surgery. And yes, for the information, psychometric property actually means validity and reliability, which Siddharth has explained really very beautifully. So there was an approval from the local research ethical community in accordance with the Declaration of Helsinki, and written informed consent was taken from all the patients. So in between 2014 and 2016, that means almost over the period of 15 months, there were 177 consecutive patients. I think the most important part is that the patients were taken consecutively, which actually increases the weightage of this general. So 177 patients undergoing foot and ankle surgery were included in it. And there were 3 timeframes at which scoring was done. So time 1 was when all the scores, which is MOX, FQ, CFAS, FAOS, SF36, and NRS was completed. And that was done 3 to 14 days before the surgery. And then just morning before the surgery, MOX, FQ, and CFAS, which is the 2 primary outcome measures that were supposed to be compared, were checked again. And the idea for checking this again was to just ensure reliability by comparing the MOX FQ done 3 to 14 days prior and then on the day of surgery, and same with CEPHAS as well. And then the third score was done 6 months post-operative. It actually included all the scores again for detailed analysis and testing. So then after that, they were obviously statistically analyzed. So I think I'll just again talk about what all things they look for. So particularly for reliability, they looked at 2 things. The first one is reproducibility, which is again test to retest reliability. That means that when you test it again after 1 day, 2 days, or a week later, you don't expect it to change significantly. So this is also called as, this was measured in the form of intra-class correlation coefficient, which should be more than 0.7. And when they were testing reproducibility, basically they were testing it for MOX, FQ, and CFAS, and they were comparing it with time frame 1, which is 3 to 14 days prior to the surgery, and then the second one just on the morning of surgery. The second thing was internal consistency. The internal consistency actually means that the items which is within one particular scale, for example, pain, the questions of the pain in MOX FQ, or the questions for social interactions in MOX FQ. So the items within the scales are homogeneous. And when you mean by that, that means if there are 5 questions, in particularly pain, for example, then the answer of one should not be 4 and the other should not be 3. So that means the scales are all homogeneous and the score actually is almost in the similar lines. So for that, they use what we call as Cronbach's alpha coefficient, and they said 0.7, 0.8, and 0.9 were the readings that they considered, and it was considered to be fair, good, and excellent degree of internal consistency. So I think when I read about it, I think 0.7 to 0.9 is the most ideal. Anything less than 0.7 means the items are not really consistent. And if the items if the score is more than 0.9, that means probably there's an element of duplication as well in the question. That means the 2 questions are actually almost similar if they are so homogeneous answers. Then the third thing that next thing that saw was a floor and ceiling effect, which means that more than 15% of responses should not reach the lowest or the highest possible scores. The next aspect was the validity of the construct, which means the extent to which a particular score relates to the other scores. And in this case, I think they compared MOX FQ subscales with the SE, FAS, FAOS, SF36, and NRS, pain and disability. And as expected, a high correlation was expected between the subscales of various groups. The next part is responsiveness, which also was mentioned by Siddharth. So responsiveness actually calculates the extent to which a questionnaire is able to detect the change over a period of time or after an intervention or after a surgery. So you actually look at how much is the score before and how much is the score after. So if the score is actually, there's a lot of difference. For example, it changes from 60 to 20, that means the score is highly responsive, versus a score which changes from 60 to 40, that would be less responsive. So they are measured by effect size and standardized response means, which is more statistical, but effect size means the difference between the means after and before treatment, divided by the standard deviation of same measure before the treatment. And standardized response mean is the same numerator, but the denominator being the standard deviation of the actual change. Then minimal important change and minimal detectable change are two other terminologies which are used, and I'll just repeat it again. So minimal important change is the smallest change in the outcome which is found to be either important or clinically relevant, which is found by the patient or the physician. And minimally detectable change is the minimal amount of change that can be considered above the threshold of measurement error. So which means actually a true change, which is detectable. But please bear in mind that detectable change does not mean that it might be clinically relevant or important for the patient or for the physician. So talking about the results, so total of 177 patients were taken on the first timing, which was 3 to 14 days prior to the surgery. They were divided into 130 women and 46 men. 118 underwent a forefoot surgery, while 56 underwent an ankle or hindfoot surgery. The details of surgery were not disclosed in this paper. But if you look at it, when they did the scoring just before the surgery, that is on the day of surgery, which is the T2 score, only 145 or 177 completed this. And then when we talk about the third score, which was done at 6 months, I think 117 only completed all the other scores. So talking about their results, so I think with regards to reliability, the two important aspects discussed are reproducibility and internal consistency. So yes, both the scores were shown to have an excellent test to retest reliability, which was done in 2 weeks' time. Internal consistency, it was found to be strong for MOX FQ overall index and pain and walking standing, but fair for social interaction. And for SEFAS, it was strong for total SEFAS score and pain, fair for limitation of function, and low for others. And probably if you look at it, that why it was low for others. So when we're talking about internal consistency, we are actually looking at the subgroups of or the questions in one particular heading. So if you look at MOX FQ, they have already divided it into three different domains, which is walking, standing, pain, and social interaction. SEFAS actually has not really been formally divided into three different domains, but it was done by the authors. So probably that is the most probable reason that the questions in others are not really correlating with each other, and that's why the answers were not consistent. So this is again the just a table which shows a high test to retest intra-class correlation coefficient for both the scores, as well as a high degree of internal consistency in both the scores as well. So there were no floor and ceiling effects noted. And with regards to construct validity, yes, correlation was made between MOX FQ and the corresponding domains of the other scores as well. And it was found that the walking standing domain for MOX FQ, there was a strong correlation with the similar kind of domains for other scores, like SEFAS limitation of function, foot and ankle outcome score, activities of daily living and sports and recreation, and SF36 physical function. So MOX FQ pain also correlated or strongly with the pain variants of SEFAS, FAOS, SF36, and NRS as well. Social interaction for MOX FQ correlated strongly with FAOS quality of life and moderately with SF36 social function. And there was low correlation between MOX FQ domains as such with SEFAS, others, and SF36 general and mental health subscales. So responsiveness, I think both the scores were showed a positive or a significant degree of responsiveness, but it was better for MOX FQ subscale. So there was a high responsiveness between the pre-operative as well as post-operative, which means the larger degree of post-operative change was detected in that score. In SEFS, it is moderate responsiveness, which means there's a good degree of change that was detected. So in form of responsiveness, MOX FQ was found to be better. So I think just a bit of heads up obtained about patient-related outcome. So the most important part is it is reported by the patient and it is not reported by either a physician or nurse. How do we do it? In most of the cases, these are done by self-administered questionnaires. So you give a questionnaire, hand out to the patient, and the patient understands it and fills it up by him or herself. But another way of doing it is by doing an interview. And when the interview is being conducted, the interviewer just takes the views of it, but you should make sure that there is no element of professional assessment or judgment made by the interview based on the answer. So the question should be fairly straightforward, with the answer can be given by the patient, and there is no component or no element of a judgment made by the interviewer. So they are generic or condition targeted, and we have had discussed this before. So generic being the most commonly used SF36 and VAS. The score itself should be valid, reliable, responsive, and acceptable. So we have already discussed about valid, reliable, responsive, and acceptable means something that is easily understood by the patient, and the patient does not find it difficult to answer. So just another thing. So as such, I mean, this, if you talk about gold standard foot and ankle score, I think there is no score which has become a gold standard as yet. But yes, there are lots and lots of scores which are being validated now. So MOX FQ itself, if you look at it, it has been translated into a lot of languages. So German, Italian, Turkish, Persian, and Spanish to name. And it has 16 questions, so the number of questions are slightly higher, so that might reduce the acceptability factor for MOX FQ as compared to SEFAS. But considering the fact that it has translated into all these languages, so it makes it a more internationally acceptable score. SEFAS as such originally was English, and then it was primarily started off as a 12 question SEFAS score by Swedish only, and then it has been incorporated in German as it. So it is still a relatively new score, and the acceptance of this score or the outreach of the score is not as wide as MOX FQ at the moment. And they both actually show good validity, good reliability, and responsiveness in the patients. So this is a bit about just a summary or recap of what I have already discussed. So they had good reliability, consistency wise. I think primarily most of them were strong, except for poor for others was safer. No floor and ceiling effects, and responsiveness was slightly better for MOX FQ as compared to SEFAS, and both have a strong validity. So this is my take on the paper. I think the strong points of this paper, it's a consecutive series of paper. There was no description about the level of evidence, and I also had a confusion, but my I felt it is level 1. I think I would like to take the opinion of the other panel members as well as of the audience about what they feel about the level of evidence of this paper. And I have a I'll present another slide which actually talks about level of evidence for outcome papers if when you're talking about them. So 177 patients, I think it's a good number. They're talking about two well-established scores and compared with the other standard score, which are even more validated, like FAOS and SF36. They have tested the psychometric analysis by all means that they should. I think reliability, construct validity, floor and ceiling effects, responsiveness, as well as MIC and NDC. So this is what I was talking about. So I think when we talk about the scores, sorry, we talk of them in the outcome scores measurement. We talk of them in study of diagnostic tests, and level 1 is testing previously developed diagnostic criteria in a consecutive series of patients and a universally applied gold standard. So this is in this case, I think the diagnostic criteria, both of them have already been developed previously. It's not something which they are developing right now, which goes in level 2, and they are doing it in a consecutive series of patients, which they did as well. Universally applied gold standard, I think it's a bit controversial, because there is no universally applied gold standard, but considering the fact that they have used some valid scores like SF36 and foot and ankle outcome score, so I think probably that might come under this level. So this is my take on this paper. Talking about the negatives of this, I think high dropout rates. So if you look at the time score 2, when they were tested on the day of surgery, only 81% actually filled up the score sheet, and on T3, which is 6 months after, 117 patients out of 177 original patients, which means only 66% actually filled up the score sheet, which is like a dropout of 34%. I did not really like the discussion content. I think it was more of a repetition of what is already described in the results. I think I wanted a bit more in the discussion about these scores and about why did the author choose these particular scores for validation. But I think that was missing. Discussion primarily was just a repetition of what they have already said. And so that's why there was nothing much in the discussion to talk about. I think there was a bit of callous writing and proof reading. So first of all, I think I also got confused initially, because initially when they're talking about which test to be done at which time frame, so T1 and T2, this initially in the methodology, they written that all the 5 tests were done, and at T3, they were asked to compute MOX, FQ, and SEF AS a last time. While in the results, actually, they wrote down what they actually did, which was actually doing MOX, FQ, and SEAF in T2, and in 6 months, which is at T3, doing all the tests. So I think there was a bit of discrepancy. So when I was reading the original, I was getting a bit confused when I read the result. Then second thing, with regards to internal consistency, I think specifically, I think for me, I got a bit confused because I probably am not a great, in statistician or, reading about these outcome scores. So it was not very clear about what do you mean by a strong degree of internal consistency, because at one point of time, they did mention that 0.7, 8, and 9 means fair, good, and excellent, but they did not use these terms in the discussion, and they used something like strong internal consistency for 0.83 score. So that is why I went back and read it. And yes, 0.8 to 0.9 has been mentioned that this is like a good internal consistency. And as I mentioned before, that if the score is more than 0.9, that means that probably there's a component of duplication in the items within that particular subscale. So to conclude the paper, and this is the conclusion which is given by the authors, so both the scores demonstrate good psychometric properties, and they both can be used as a tool for evaluating efficacy of surgical procedure or in clinical trials to assess the outcome. MOX-FQ has a higher responsiveness, and hence they are able to detect changes over time or post-intervention to a greater extent as compared to self-reported foot and ankle score. And the other thing is that MOX-FQ is available in more languages, so it has a wider international distribution. So that's why I think MOX-FQ scores slightly higher to self-reported foot and ankle score, at least at this point of time. Thank you very much.
Thank you, Dr. Anuj. Nice elaboration and detailed analysis of the article. Really love it. I have a suggestion. When you have studied this article in such a great detail, it's really worth to write a letter to editor, because even they will take note of the detailed points which you have noted. And it's worth, I mean, I will request all of us, when we are conducting some journal club to this detailed extent, worth to write letters to editor, and they do take care of your letters. They do publish even your letters. It's really worth. Thank you for reading this paper in that great detail.
Thank you very
So
much, sir.
yeah, so you have raised one important point, is which even will put it across our panel, that what is the level of evidence really this paper is, because honestly speaking, I will not be able to guide you what this level of evidence is. Can Dr. Vikrant or Dr. Siddharth or any one of us help him to know what is really, because he has put his points, and I do agree with those points. According to those points, it's level 1, but I don't know, subjectively, we may not say that this is an level 1
That's true.
evidence. Yeah.
That's true. I mean, if that is level 1, I think it's very easy to make level 1 evidence with any research outcome paper.
Yeah.
So that is why I was a bit confused. It didn't look like a level 1 study to me, but based on what is written, it sounded like a level 1.
Yeah. Anyone can throw light on it, Dr. Vikrant or Dr. Siddharth or Dr. Rajiv sir? Anyone about the level of evidence?
So I think that there is no gold standard still yet. That is the
Yeah,
problem. So to reach a
that's true.
level, to really come into this, so we are trying to reach that standard slowly and gradually. So this is a gradual process towards going. So it is really difficult to say that it is the final answer to the solution.
Yes, so I would agree with Dr. Rajiv sir. So getting consecutive patients is easy, but getting a gold standard, which is gold standard in the strictest sense. Now, because when they do this scoring, they do compare it with lots of scores, but those scores also have limitations. So I would hesitate in calling it level 1. It would be something like level 2 to be on the safer side. Yeah.
Okay. Any comments from Dr. Vikram? If is he listening to us, Dr. Vikram?
Yes, yeah, I'm listening to it. I think it is. I'll agree with that. I would be skeptical in calling it a level 1. Level 2 is what I would call it. Yeah.
Great, great. And then one more question to you, Dr. Anuj. As I heard you that you are using yourself this score marks FQ. So is it? Can you calculate straightforward, because like SF36, it's not that the way numeric like AFS score, that this is
Yeah.
30 and this thing. So is it? Can you calculate straightforward? I mean.
Yes. So I think with respect to Mox FQS, I mean, as I mentioned that I was using it more often in UK and in Singapore. So what we used to do, we had a spreadsheet or an Excel sheet in which we just keep on entering all the data, and then finally the overall outcome score is just calculated by from 48. They would just numerically convert it to 100. So I think that you have to do that amount of bit of modification in your Excel sheet, and then it becomes easy. It is easy to enter the score eventually once you do that.
Yeah, I think that is the main point why AFS score and MOX FQ is most commonly used, because you can just put in and you can calculate the score. I don't
Right.
know whether this is true with SF36. Do you have experience to chart your patients according to SF36? Do you think that it is that?
No, I have not charted the patients on SF36, but I think my personal take is that any questionnaire which has more than 20 or 25 questions and you give it to the patient, it becomes difficult for the patients to answer all of them in totality and in actual sense as well. So that is my take. So what we used to do is we used to just do a VAS and something called as EQ5D score, which was done in UK. So that's basically just telling your the percentage of health. With 100% is the best and 0 is the worst. So how healthy do you feel? Which is almost as same as NRS actually.
Great.
One more question to Anuj. Uh, have you been using this score for all like trauma and all
Yeah.
your surgeries, or any specific, like in certain papers it was used for osteoarthritis, it was used for different specific conditions. So what is your
Yes.
experience there?
So I think for me, I have when we have used it. So we've used it for all the surgeries. I think it is not just. I think whether the score is validated for that particular condition. I mean, yes, the most significant validity is for hallux valgus or forefoot surgeries, and not that much for the ankle arthritis related. But I think then it becomes a matter of convenience for the surgeon as well, and for the whole process, that if you have one particular score and you're doing it for every patient, I think maintaining the scoring system is easier.
Yeah.
So in that sense, I think, yes, it might not be the most ideal thing, but I think practically, if you look at it, we can't really measure different scores for different patients. And in
Yeah.
the end, I
Yeah.
think the process would be lost.
So you used it for trauma too?
Yeah, we use it for everything. I mean,
Okay.
frankly, orthopedics, Oswestry was not really a trauma center. It was more of an elective orthopedic center.
Okay.
But yes, every patient that comes to the hospital, and I mean, frankly, I mean, there were few uh, cases in which a patient has a carpal tunnel syndrome, but because the system was so well set up that the carpal tunnel syndrome came up with the most FU scoring. So it was so, the system was so much into place. Yeah.
Ajay sir,
Yeah, just was saying it's application in trauma. So how do we take the pre-op? Means we might not be able
Yeah,
to
so
take
I
pre-op
think,
scores in this case. I don't think we can
yeah,
apply
so
this.
yeah, I don't think particularly we can apply it particularly with trauma, but yeah, so we did not used to take the pre-op scoring for the patient. It was just a post-operative. But as I mentioned
Okay.
again, that Oswestry was not primarily a trauma center, so we had hardly, I mean, 2 to 3 traumas in a month,
Ma.
which is not a great amount. But yes, so that is why I think probably we didn't really focus on the trauma aspect particularly.
No, even otherwise, I think all these scoring systems we can probably apply them only to conditions like, say, all the painful
Yeah,
conditions and
more,
all the deformities only, not
which
to
is,
trauma. Trauma, I think we can only apply post-op. We can just see
yeah,
how well they return to a function, and we
that's
might
true.
not be able to get a pre-op validity in all of them.
Yeah. So even in trauma, I think, well, if I mean, till the time the patient is on the cast or on a walker boot, so generally around 6 to 3 months, the scoring did not make any sense. It is only after 3 months that the score starts making sense. So that is another thing.
are there any questions? There was one question that.
So, Sampath sir, one small comment.
Yes, please.
So, Anuj, you pointed out very correctly that on the probably the 6 months follow up, they had a 60% response rate. So, 40% loss to follow up is not really unacceptable. And yes, you said that this is one of the points that goes
Drawbacks.
Went it from
against.
level 1.
Good. So there was one more question that.
Because missing data does affect the outcomes of any study.
Sorry. So there was one question that whether you can use these scores like SF36 scores, are they free and are they available? In fact, I saw so many help online to calculate your scores. You feed those answers and they will calculate a score for you. So all these helps are available online if you Google them. So yes, probably they are free and you can use it for your own articles. I don't think that we need permissions, isn't it?
No, I don't think we need permissions, but I think the reason for putting the scores on this platform also, I put up, I think SAFAS and FAOS is widely available. I think MoxFQ not so widely available. So that is the reason of putting it, so that if people want to see it, probably they can have a look at it.
Great, great. Thank you so much. Are there any questions for Dr. Anuj? I read the questions which were there, and I think, thank you, Dr. Anuj. Shall we go to the last article by Dr. Siddharth, and then we'll come back if there are any questions. Over to you, Dr. Siddharth.
Thank you, sir. So, Sampath sir, can you see the screen? Is it okay?
Yes, perfect now, sir.
Yes,
Go ahead.
sir. So the article that I am going to be presenting is from the Foot and Ankle International Journal, and it deals with symptom and disability measurement by common foot and ankle specific scoring systems. And the author is Dr. Siradsky from the United States. The Foot and Ankle International is actually, I think, the best journal when it comes to foot and ankle research. It has an impact factor of 2.3, and the level of evidence for the study is level 2. It is from the latest issue. In fact, it is ahead of print. So why did I choose this article? So for the simple reason that if you are going to be scoring foot and ankle outcomes on patients, you need to also see what is the patient's perspective. So as surgeons, we may think that this is important or that is important, but you also really need to find out whether the thing is important to the patient. And we have been talking about this all evening. Now the patient reported outcome measures are more important than perhaps what the surgeons feel. We've seen that there are a number of prompts that are available, but we also need to find out whether the questions in those scores are relevant to the patients. So the authors got the inspiration from the study, from a similar study that was done for knee specific scores, and the study was by Tanner et al. So they wanted to see really which questions were the most important for the patients. And because it's a slightly complicated article, I will break down the methodology into 3 steps. So in the first step, they chose 3 categories of people or patients. Now, mind you, only 3 categories. The first was osteochondral lesions of the talus. The second group of patients was those with instability. And the third was those with osteoarthritis. Now, to these patients, they gave a score or a questionnaire which had questions from 16 different scores. So mind you, these people almost had to answer 100 plus questions, but they had the subjective elements from 16 different scores. And then finally, they devised their own way to rank this, and then they tried to find out for each category of patient, which is the most relevant score. So this was a prospective comparative study. They got all their due clearances. I've already told you what were the 3 subgroups. The intervention, of course, was the survey. So let us look at the step 1, which is the patient selection. So all the 3 groups, they only included patients who were more than 14 years of age. If the patient was post-operative, the patient had to be at least 3 months post-operative, but they also included non-operative or pre-operative patients. And the patient should be able to speak or read English fluently, of course, because all the scores were in English. So in the next step, they chose 16 common scores. Now, 6 of these were general scores, 4 were specific to ankle instability, and 3 to arthrosis. And from these scores, they got 241 questions. Now, of course, there were a lot of questions that were overlapping. So after deduplicating, they got 151 questions which were reviewed by fellowship trained surgeons, and they did pilot testing on patients to know whether the patients could really answer the survey. Now, for each question, they asked the patient whether or not the score was, the question was important to them. And then this assessment was done on a Likert scale from 0 to 5, as you can see here. And because the overall survey had about 150 questions, it took 35 minutes for each patient to complete this survey. Now, mind you, I'll come back to this. This was one of the limitations of the study, actually. So in the third step, they devised a ranking system. Now the ranking system is a little complicated, but to just simplify, they broke down this thing into 4 parameters. So for each score, they look at the number of questions which were endorsed by more than 51% of the patients. They also looked at the questions which had a Likert score of more than 3, which means that they were important to the patients. They looked at the questions which were not important to the patients, that had a score of less than 1. And then they also looked at the questions with a top 20 FIP score. Now the FIP score is a frequency important product, which simply means how many patients experience the symptom into the average number of score. So now let us say that if standing hurts your knee or standing hurts your foot. So if 50 people report that they have this symptom and the average score for these 50 people is 3, then the FIP is 150. So coming on to the results, now a total of 109 people actually got enrolled into the study. The osteochondral lesions were 39, instability and osteoarthritis were 35 each. You can see the demographics here. And when it comes to the overall assessment of the score, the foot and ankle outcome score was rated the best in all the three groups. Now, this was followed by the foot and ankle ability measure, and the third overall was the AAOS score. Now, mind you, the IFAS score and the other scores which were commonly used were very down in the list, as you can see here. So in the osteochondral lesions of talus, again, the FAOS is the top one. The IFAS is actually quite down. You can see here in the list. So it is quite down. Again, for the ankle instability as well as for the ankle arthrosis, the foot and ankle outcome score performed the best. So now this actually shows that the FAOS is a very good score. This is, like Anuj has already said, this is an adaptation of the knee osteoarthritis outcome score. But the problem here is that it has been validated only for ankle instability, adult acquired flat foot disease, and hallux valgus. So if you have other conditions, we can use the number 2 and the number 3, which is the foot and ankle ability measure and the AAOS scores. The foot and ankle ability measure, like Anuj and Vikram both have told, this is a general purpose score. It is highly validated, and it has also been validated for chronic ankle instability. The AAOS is a recent score, but as Vikram has already pointed out, I think Anuj as well, that you need to enter this on a computerized scale. So that makes the usability of the score a little difficult, right? So the strengths and weaknesses of the study. So the strength, of course, is the good sample size. 109 patients were included. They looked at 16 scores, which is practically most of the scores. The MOX-FQ surprisingly was not included. They had a strong methodology. The weakness, of course, is the frequency, importance product, which is not really a standard measure. And then there was a high percentage of post-operative patients. So when you have a high percentage of post-operative patients, it tends to skew the overall scores. So what does the study add? Now it gives us a very good perspective on what questions are important from the patient point of view. And it shows us that the foot and ankle outcome score is actually a very good score, and we need to validate it for other foot and ankle conditions. So to conclude, the FAOS, the FAAM, and the AFAS all captured the patient's perspective well. And coupled with the fact that these are, validated scores, we may start using them in our routine clinical practice. Of course, the score should also be easy to administer. So on a case-by-case or a surgeon-by-surgeon basis, we may decide to use one or more of these scores. Thank you.
Thank you, Dr. Siddharth. Great illustration. I think, again, some of them, they are disease specific, isn't it? Now, here they have considered it for the OCD lesions, ankle arthritis, and
Instability.
Ankle instability.
So that is what. So we have talked about generic, we have talked about regional, and now it is disease specific. So many points have added to our knowledge, because now next time when we are going to use this score, I will keep it in mind, not the commonly used score, but I will keep it in mind the region specific or the disease specific. I mean, it's good. Most of the points we have discussed. And any questions to Dr. Siddharth from any of our panelists?
Yeah, hello, Dr. Siddharth. Very nice presentation indeed. You correctly pointed out that FAOS and FAM are good scores which can be used. AOS, I think it's a bit impractical because they have the Excel sheet on their web link. Anyways, I just wanted to know, we talked about minimal clinically important difference. Does FAOS have a particular value for it? One, and so when we see a post-operative score and we see, for example, a study has a mean pre-operative score of 30 and a post-operative score of 50. And with other interventions, the post-operative score is 80 in patients. Considering the population is homogeneous, can we say that one particular intervention is better than the other, or it just means both improve significantly?
So Vikram, yes, I mean, this is a really difficult question for me, because I have not really come across many MCID publications as they deal with the FAOS score. But to be completely honest, I have not really researched into this well. So point well taken. We probably need to look into whether any MCID calculations have been done for this particular score. But to the best of my knowledge, no, I don't think there is an MCID value. Regarding your second question, what percentage of change should we be looking at? So of course, when you talk of research papers and other things, we think that a 15% or a 20% change is clinically or a relevant thing. But now this thing is so arbitrary, because when you talk of things like mortality, even a small change may be important. But when you talk of morbidity, larger changes may also be acceptable. So there is no really good way to answer this question. And the only way to do this now, a lot of research on PRP is coming up, and all of them are talking about MCID. So I think in the context of foot and ankle research, also we need to define what is the MCID, and not just for a general score, but also in context of the disease. So what's the MCID for an osteochondral lesion? What's the MCID for an ankle arthrosis? So this is more areas of research which hopefully we will see in the future.
Okay, thanks, Dr. Siddharth. Okay.
Great points made. Over to you, Dr. Ajay sir and Dr. Rajiv sir. Any comments to the speakers or for our viewers?
I think it's a wonderful presentation we have from all of them, and we have learned a lot. And then we have learned that we need to listen to our patients, because these are the scores which are coming from the patients. And then the other thing which we have learned is that we need to ask the questions which the patients think they're more important. It is not what we think which is more important. It is the patient thinks that it is important for him. So these are the things which are to be incorporated into developing of the scores. And how you interpret the scores, at least my knowledge has increased a lot. I don't know, I was little juvenile in this thing. I would say probably we have been brought up in the earlier times where these status and all these quotients and computers were not there. So we had a different, but definitely it has added a lot to my knowledge, and I'm sure it has added to all the audience who have been listening to this.
Great, thank you. Any comments, Ajay sir? Because I will really like to congratulate our executive committee, our president sir, secretary sir, for taking this great initiative of Journal Club. Ajay sir, say a few words.
Yeah, that's what. See, it was just the initiative. The success is because of the way it has been conducted, Dr. Sampath, and excellent. You have chosen the topics also quite correctly, and you've given them the choices, the order in which they need to present, so that each and everything was actually built up. So starting from what a score is to which are the important scores, I think it was actually very well built up. And each of the speakers were excellent. I think all of them presented extremely well. They were thorough with the articles that they've read, and they brought out all the salient points which are required. I think that is one of the reasons I think we could learn so much from this entire journal club.
Right. I will really suggest those presenters, really, you can write a letter to editor, because this is the only time when we study those articles in detail, and it's really time to write to them. You will get some answer, and they will also get some inputs really when you study in that great detail. And few points to all of us, we have studied few points. One is, as we discussed, for Indian patients, sitting cross-legged, squatting, walking on uneven surface, walking bare feet. These are very important points which we are studying and we are trying to include, because anyone, even at home, we walk bare feet. And if you study those particular parameters, our patients are going to give you a lot of feedbacks. Look, I am able to walk bare feet. I'm able to walk on uneven ground. I'm able to put on my chappals. So many good points we will inculcate in our scoring system, and let us formulate some scoring system where it really helps our people. Over to you, Ajay.
Yeah, I think so. I think, yeah, that's what I think. The whole idea is that we should also start looking at having a score called the IFAS score or whatever we can call it. But then these are the points which we need to include. And now that we have a fair idea as to how we can go about formulating a score, I think we should start working on it at the earliest possible. And of course, Siddharth has already promised yesterday, even during the meeting, she was just mentioning that more than act, uh, more than active to be helpful. He's quite enthusiastic. And I think we soon should be looking at something which the world can look up to. Right? Okay. So, should I think there are any other
Can
questions,
conclude.
Dr. Sam? Yes.
There
Any
are
other
no questions. No questions, sir. From
no questions? I think so. I think so. Then maybe then I would like to thank everyone, all the presenters, all the panelists, and Dr. Raju Vora, Dr. Sampath for being in on this and for conducting this in such a smooth and excellent way. A lot of learning for every one of us. And unfortunately, Dr. Dhillon is not there, but my thanks out to him too, also because he's been mentoring all of us. And that's about it. And thank you all so much. And excellent way of